Well, thank you for that terrific talk. Our next talk is by Dr. Daniel O'Connell, and it's entitled Physician Wellbeing. Are you suffering more than makes sense? Which the whole concept of physician well-being is kind of a new topic and should be very interesting. Dr. O'Connell is a clinical psychologist who lives in Seattle, Washington. Over the last 35 years, Dr. O'Connell has worked as an educator, consultant, clinician, department chair, and executive director in medical, behavioral health, and educational settings. He is consultant to the Institute of Healthcare Communication and serves on the faculty of the Foundation for Medical Excellence. He teaches in the residency programs at the University of Washington School of Medicine. Dr. O'Connell also maintains a coaching and consulting practice working primarily with healthcare organizations and individual providers on all aspects of the psychology of medicine, leadership in healthcare settings, and professional interactions. Dr. O'Connell develops educational programs for healthcare providers, groups, and institutions, and has led more than 500 workshops on various topics in the psychology of relationships and communication in healthcare. He created a program for the disclosure and resolution of adverse medical outcomes that is widely taught in the United States and Canada. And there we go. Oh. Welcome, Dr. O'Connell.
Usually I wander around, but staying at the podium might be my better deal here. So as described, I am a psychologist, and I spend half my time in a large medical group in Seattle where I was the chief of behavioral health for 15 years, and the other half of my time is at UCLA or UW, where I spend time either with my physicians as my patients or medical groups as my patients, and we look at the psychology of the interaction between healthcare providers, their patients, each other. And a giant topic has been this whole question of why are physicians and nurse practitioners and PAs acting, reporting, and feeling so fried? So that's what I would like to help you with and offer you some suggestions that may not be so obvious to you. But let's see what we can do and then hopefully have some time for questions. Aside from flying me down here and impressing me with how beautiful Ogden is, I have no other financial conflicts of interest. The goals are a couple, though. I want to help you differentiate. Like you are talking to a shrink, real from unnecessary suffering. There, as you know with your patients, you can see 3 patients in a row with the same MRI scan with foraminal narrowing at L4, L5. One of them is totally disabled. One of them wants your help so he can continue to coach his son's soccer team. And the third one's looking for complete disability. And you look at their scans and you say, I cannot explain the level of suffering and disability based on these scans. So we see the same thing in medical practice. There's levels of suffering going on reported among doctors that does not easily explain by the job itself. So we want to kind of understand what is going on here. How do you uncover the sources of distress? And I think like you tell most of your patients, good advice is never suffer more than you have to, right? As a matter of fact, that's probably the wise man's approach to living. So I want to develop some antidotes if you come to recognize you are suffering more than makes sense. And then finally, those of you who don't know this Serenity Prayer, who haven't had the good luck to be a drug addict or an alcoholic, will, because if you've been a drug addict or an alcoholic and you've gotten sober, you realize the Serenity Prayer is one of the most beautiful pieces of wisdom ever done. Serenity to accept the things you cannot change, which is really quite a lot of things. Courage to change the things you can, but using that courage sensibly, protesting, whining, complaining, echoing, saying that Obamacare has ruined America, that patients don't take care of their health, that insurance companies are out to get you, that every patient wants to sue you. That is not courage. That is wearing you out, and it's, by the way, histrionic if you want a diagnosis from a personality disorder perspective. So we got to differentiate what is courage and how do you use it wisely to change the things that really need to be changed. Where would serenity make a heck of a lot more sense? And then finally, how do you know the difference? And we'll come back to that a time or two. There are plenty of real reasons for physicians to feel like they're suffering. Constant change, enormous change. In the time that I've been practicing, it's unbelievable. right? And I was doing a program for endocrinologists in Seattle yesterday, 10 endocrinologists in a group, 2 of them so burnt out you could smell fried flesh in the room walking in there. But if you listened to them, but the other 8 are not burned out, and 3 of them are thrilled to have a chance to be practicing endocrinology. How do you make sense of this stuff? But we also want to understand, how could you make things worse than they really are, and how do you know if you are suffering more than makes sense? So here's a definition of burnout. When the load consistently exceeds the capacity, practice becomes unsustainable. So not everyone has the same capacity. You're not printing presses. You don't all put out 125 horsepower. Different physicians at different points in their career with different practice settings and supports can do different levels of work safely. But I think the comment that I heard at the end of the last speaker's talk was very, very important, right? If you're seeing more patients than you can safely manage, then that's going to be corrosive to your own sense of what it means to be a doctor, and is going to leave you constantly concerned that somebody's going to sue you. And so we're going to look at stress from a number of perspectives, because it's not simply Obamacare and the EHR that's making us crazy. It's some of the decisions we're making in our own practices. So the factors that we see in physicians who seem to be able to enjoy the practice of medicine are, they do exert some control over their practice environment, but they don't try to control the things that can't be controlled. They also have reasonable work demands, which means they're seeing enough patients to make money, but a reasonable amount of money, right? They're not trying to get wildly rich and then cranking up their personal expenses to a level where no amount of income can support their 2 homes, their 4 children in private school, their late model cars. It's just not possible. We're creating our own stress. They get collegial support, so when they're in a group, they don't practice alone together, but they actually practice and they trust each other, and they get support from their colleagues and from their staff, and they experience a great deal of satisfaction talking to patients. I mean, I think unabashedly, I teach in a medical school, I'm not a doctor. I think being a physician is one of the most blessed professions available to anybody right now on earth. To be able to use the kind of intelligence you have, the science that's available to you, to do the kind of good and alleviate the kind of suffering that's available, I do not see another career that offers this promise, as well as pays 5 times as much as my daughter's 5th grade science teacher, who may also be living in your community trying to find a life, raise children, and she's got to feel satisfaction, and she makes 1/5 of what people in this room do. So it can't be that money is necessary for satisfaction, because otherwise the rest of people should be in my office or hanging themselves. So 4 keys to sustainability that are worth watching. The first is energy. Is energy renewal possible throughout the day, in each moment? Well, as we'll see, many clinicians go to work each day with essentially a psychology that says, I'm a bucket that got filled up. I'm going to be drained as the day goes on. I hope to make it to 4:30 before I'm empty. Or if I am empty at 4, I'll fake it for the last half hour. But that's a crazy way to live, because the physicians who are not burned out, what they tell you is they find satisfaction through the day. They like talking to Mr. O'Connell. They knock on the next door and they say, on the other side of that door is a person, somebody's husband, somebody's wife, somebody's mother, somebody's daughter, who has some kind of medical problem or is worried about one, or thinks they have one. And when I knock on that door and I enter that room, I am ideally suited, because I've been in school for 48 years, to actually help them. What a beautiful way to roll through the day. Unless you're knocking on the door saying, here's another one, and another one, and another one, and an endless parade of people, none of whom will get better, none of whom listen to me anyway. All of them have Medicaid. I'm losing money to see each one. I hate this. My MA's an idiot. My practice manager's a greedy witch. Obama, I can't wait till he gets put around. Oh, next patient, please. But some of you are laughing. Have you been in conversations in the last week where that was essentially the echo chamber? Have any of you started to avoid the doctor's lounge at the hospital because you went in there feeling some sense of well-being, and in minutes you were grinding your teeth? Presence, the human connection, is one of the biggest satisfiers in medicine. If you look at research, physicians 7 years out of practice, the highest correlation with satisfaction is their relationship with their patients. You just cannot churn through these people at this rate and be happy. There's not enough money in medicine to make up for the fact if you're not having some degree of fun, some degree of satisfaction in every interaction through the day. And then finally, time efficiency, I think, is really important, as is mindfulness. The physicians who like this work, they tend to be present, right? That they're minded. When they knock on a door, they pause. We even teach this in a course on mindfulness-based stress reduction. But essentially, in minutes, we have physicians who say, before you knock on that door, you have to take 3 breaths. On the out breath, you have to say, relax and let go, because there's a lot to let go of as you run from room to room. Then you knock on the door, and before you walk in, you say to yourself, on the other side of this door is a person who needs my help. And then you knock on the door and you walk in and say, hi, Mr. O'Connell, I understand you're having a problem with your stomach, some prescription refills, and some concerns about a mole on your leg. I'm glad you could come in today. Let's see how much I can help. That tends to be the presence of physicians who like the job the best, right? And by the way, they are also more time efficient, because let's be reasonable. If you're late for every visit 25 times in a row, apologizing to 25 people, if you're not peeing, if you're not eating, if you're charting till 9 o'clock at night, confabulating, because all 25 patients have merged into one protoplasmic mass, and you haven't seen your children grow up, you're not going to like this job. If you have 20-minute visits, I coach all day long on this stuff. If you have a 20-minute visit, you have to find 20 minutes worth of work to do. Now, I'm not here to teach you efficiency in the medical visit, but that's half of my work life. But the doctors, we've got to get on time. We've got to create agendas with people that are reasonable. We have to negotiate how time is going to be used, and we have to get focused, because so many of us are so far behind that we're endlessly stressing ourselves out, and we're getting clobbered for it, and it's not absolutely necessary. So here's a long quote, but follow the logic. Linearity, complexity, and well-being, how they go together. Most of the people that I work with now in 3 different medical schools are trained in a model that is essentially find it and fix it. And the person who's supposed to find it is you, and the person who's supposed to fix it is you, and that does not map on the medical experience in any sane way. Because in order to find it, you have to get a person willing to talk to you about what the it is, and in order to fix it, they have to be reasonably convinced that you understand the cause of their medical problem. Right? They have to be reasonably convinced that the medication you prescribed would help more than hurt. They have to feel confident they could actually carry out that plan, afford it, have the time for it, convince their relatives to let them join a health club. Then they have to think it's important enough to commit themselves to. So you don't fix anything for the most part. I mean, you fix a little if you do procedures and you remove polyps and you implant pacemakers. That's beautiful work. I'm with you. But most of what we do to help patients do better in their life physically, they do after they leave your office. So to have a way of thinking, which is I'm supposed to find it and fix it, sets you up for burnout before you even start this career. And I have R2 residents at UCLA who are already completely in this model. And they're furious. They're mad at the patient who won't let them fix it, won't let them find it. And then they're furious when the patient doesn't follow the treatment plan, so they can't fix it. Crazy way to live. Go back to the AA prayer. Never worked was never true. Patients, by the way, remind yourself, patients are like you. They have free will. They don't have to get up in the morning and say, the most important thing to me today is to be as healthy as possible, to live to 95 so I can spend the last 10 years in a lovely nursing home someplace in the valley. No, you got people in Utah who do extreme skiing. I mean, those people are nuts, right? I ride a bicycle hundreds of miles a week in Seattle. When someone tries to tell me that my cholesterol is a little high or my blood sugar is 105, I say that's number 25 on the list of things that could kill me. And the first 20 I do on purpose. So understand, and you are like that yourselves. Most of the people I see living in Utah are like the people I live with in Washington. We don't get up every day saying, how can I be safe for the next 16 hours until bedtime? We get up saying, I got this beautiful gift of life, right? Depending on how you think about life, the universe seems to be over 13 billion years old. The planet itself seems to be over 4 billion years old. You are going to live at the outset about 90 years. Do you get the point here? You didn't design the universe. You didn't decide when to be born. How many of you thought you chose your gender? How many of you think you chose your parents? How many of you think you say, I was really smart to be born with an IQ over 130 because I would have had a hell of a time in medical school if I'd been born with an IQ under 115? How many of you are saying to yourself right now, most of the things that have shaped your life, you didn't consciously choose at all? Is that wild or what? The next time you do the serenity prayer, Remind yourself that most of the things that shaped your life, your gender, the time you were born, the IQ you had, the parents you were, the country you happened to be born into, most of those things you did not choose at all, did you? So why this obsession with trying to control everything? Why couldn't we just say to ourselves, I got maybe 90 years on this planet, I don't even know why I'm here necessarily, I may have a spiritual path that offers me some explanation, but I think many of us would go still. Even with my spiritual path, why now? Why here? Why wasn't I 19 years old in 1941? Why didn't I die on a troop ship heading into Normandy Beach? I don't know. So turn the I don't know and hold control a little more lightly, and you start to say, I got 90 years on this planet, maybe, right, in which to witness and experience and participate in creation. Is that fair to say? To me, that's indisputable. You got maybe 90 years in which you can witness and participate in creation. And most of the things in creation you have nothing to do with. Unless you think you did design the universe, you mostly should try to enjoy it. But most of us are instead protesting, judging, complaining, and lamenting, redesigning it on a daily basis, and it's killing us. Because as we see our HPA axis, which most of us have the same nervous system as your golden retriever, except you have a little bit of neocortex spread over the top like peanut butter, right? But for the most part, you got the same nervous system as the mammals for the last 200 million years, which leads you to dump adrenaline and cortisol whenever you feel upset or threatened by anything. Now, the problem, of course, is that nervous system, as you all know better than anybody, and I had to explain to endocrinologists yesterday, which was a little wild, that nervous system was well designed to deal with threats to survival, right? You hear a snap, a twig behind you. If you're a deer, right, your first thought should be run like crazy, think later, right? But now we're sitting here in this room. Most of us, thank God, are not threatened with survival, are we? Right? You could be living someplace on Earth right now where survival was a possibility, right? We could be in Afghanistan. We could be in sub-Saharan Africa. We could have been on a plane, an Egypt airplane. Who knows what happened to that one? But for the most part, most of you here are not threatened with survival. But you have the same nervous system that's been 200 million years in evolution that is geared to respond instantaneously to threats to survival, except the threats most of us in this room will experience are threats to self-esteem. Most of the threats people in this room will experience, except for those of you who are about to have your doctor tell you you have a recurrence of your breast cancer or something terrible, they're threats to self-esteem. And yet your nervous system responds with the same level of biochemical hormonal response as if your survival was threatened. That is not your fault, but you've got to get smart about this, or you're going to be shooting pigeons out of the air with essentially an anti-ballistic missile system. Endlessly. That's a problem. The false promise of control leads to unrealistic expectations, and when those are not met, you, me, all of us respond either with anger, we're pissed off at the way things are going that we don't control anyway, right? Or we feel like we're failing, or we want to blame somebody, or we feel vaguely ashamed that we're somehow not meeting our promise. I have a patient who's a family practice doc, 3 years out of residency, came to me in tears, referred by her medical director, and her opening gambit was, she said, Dr. O'Connell, I feel like for all the work I've done in life, I'm going to end up just a family practice doc. Wow. That would be 99.9% of the people on Earth's wildest dream. But she immediately starts to talk about she's not going to be on the academic faculty, she's probably not going to do original research. Did your heart break for her? Are there people in the room, you don't have to raise your hand, who drag yourself through the day saying, I'm only going to be a general surgeon. That's all I'm ever going to be. Crazy way to think. In any event, we don't give up on intentionality. It's not like you bumble through the day. It's not like you have a bowl of pills in the waiting room and say, take whatever you want. It's all random anyway. But we have the physicians who don't burn out, they tend to have a sense of intention, but they hold it more lightly, right? So like the last speaker said quite beautifully, my job is to give you my best medical advice. Your job is to decide what to do with it, right? We're only going to get confused if I think you're supposed to obey me. You did not agree to obey me. Now in Utah, you may have agreed to arbitration, But in any of the forms do you give out, is there one that says, and you will obey me? No, so get over it. My job is to give you my best medical advice. I respect it's your job to decide what to do with it. It's my job to try to convince you, right, of the science and the logic and the best practice. It's my job to help you feel more confident you could accomplish it, change the size, help you. And it's my job to ask you this question, which is this important enough for you to commit yourself to? And it's my job to be curious if you say no, because you came to see me. Right? Unless you're going down the street hijacking people, throwing them in your office and treating them against their will, which I've done periodically over the years as a shrink, but you guys don't usually get to do that, right? Then the question is, you should be curious, not furious. Doctors should not be furious, but they should be curious because patients do things that are sometimes wacky. Like they come to see you and ignore your advice. I mean, if they no-showed for the appointment, that would make sense. Right? But when they show up and the hemoglobin A1C has gone from 6 to 8 and they still can't find their glucometer and they think batteries are expensive, right? And they're guessing what their blood sugar is, how many of you would say that would make me curious? Not furious, but would you be curious? Mr. O'Connell, let me ask you a question. What do you understand a hemoglobin A1C of 10 could mean for you? What do you understand are the dangers of letting your blood sugars get that high? Mr. O'Connell, how good do you think you are at guessing what your blood pressure is? I'd be curious, right? I wouldn't be furious. I would be curious. Remember, curious leads to a lot less HPA, cortisol, and adrenaline dumping than furious does. Furious is a lot of adrenaline and cortisol dumping. In any event, so let's move on. We've said the prayer, I'll say it together. God can be whomever you want to think of this higher power, but I would remember this. Serenity for the things I can't change, which is most things. Courage for the things I can change, but I would add courage applied wisely, not just whining and complaining, and the wisdom to know the difference. I said to a group, I don't know if there are endocrinologists here, but they were all pissed off because now we've got an electronic health record, and the patients are all emailing them, right? And they want advice. Well, is anyone here an endocrinologist? It's a shame to... So here we go. I was at a talk recently that says endocrinology will be completely different in 5 years. Skyping, because most of these patients don't need to come in and be seen. What endocrinologists do is this incredibly careful Sherlock Holmes level of detective work and management of micro amounts of lab changes. Well, you know, most of the patients don't need to come in and be seen. The only reason we need them to come in and be seen is that's the way we get paid today. If managed care comes back, and it's coming, or affordable care comes back, or accountable care comes back, then we're no longer going to need to make Mr. O'Connell to drive 80 miles in traffic, right, and sit and look at your fish in the waiting room, and pay this copay in order to get results that he could have gotten by Skype or by email. So relax. By the way, how many of you voted for the electronic health record? I mean, come on now, things change. You don't have to be a Christian or a Mormon or a Buddhist. The Buddha would have said the first of the eight noble truths is of impermanence. Everything is changing all the time. Have you looked at a picture of yourself graduating from college recently? Okay. 4 ways to amplify the troubles you have. The first is if you fail to solve problems you do have, and I'm going to talk about some problems we do have. If you fail to solve problems you do have, then that's going to increase and amplify your troubles. But if you try to solve a problem you don't have, that is almost as bad. So you've got to understand where are you applying courage, and is it a sensible place to be trying to apply your energies? If you use the wrong solution, that's not going to help. Right, and then finally, using the right solution unskillfully. So let's go through each of those things. But keep those in mind, because it's a nice way to make a diagnosis. And by the way, if you're not sure about this, go home and ask your spouse who's not here. Am I trying to solve problems I don't have? Yeah, you're trying to get Tommy to behave more like Brian, and they're different people. Right? By the way, if you bought a golden retriever and you don't like a dog who sits in puddles and wants to play with a tennis ball, you got the wrong dog. Don't try to change the dog into a poodle. It is too late. Right? And by the way, if you drag this dog home, try to love it the way it is, please. In any event, there's 2 types of problem solving, assimilation and accommodation. Keep this in mind. Those of you who have your smartphones out, you're going to want to Google this later or now. Assimilation and accommodation are simply this. Most people's preferred mode of problem solving, me included, is essentially what we call strategy 1, and it is more of the same. Go faster, talk faster, type. I was coaching a physician the other day who runs down the hallway, knocks and is knocking on the door as it's opening, talks a mile a minute. I grew up in Manhattan in New York City, and I drink coffee. I can talk fast. This gal had no excuse. And then this is how she wakes up the computer. I'm a nervous wreck within 15 seconds of seeing people with her. Why is she doing this? She's in a hurry, right? How many of you in this room, when reimbursement started to go down, said to yourself, the way I'm going to maintain or increase my income is I'm going to see more people for shorter amounts of time? How many in this room spend a great deal of your time trying to figure out how to extract more income by doing some stuff? I don't want to get myself in trouble here, but we have 3 university faculty members who are up for ethics violations because what essentially they've been doing is printing money using Epic. Does anyone here use Epic or Cerner or electronic health record? It turns out it's very easy to print money using that machine. You just check a lot of boxes and you code everything a level 5. Well, some of the patients didn't like this because they didn't have insurance. Like me, they have a $5,000 deductible. So they're getting bills for $495 for a 15-minute visit. What would you do if you had to actually pay $495 and you remember being in the doctor's office for 15 minutes? So they get curious about what a level 5 visit is. And I'm shocked it's taken this long for patients to come after us. Because I sit on the edge of coding workshops that are frankly fraudulent, where the coder's essentially saying, if you want to get paid a fortune, do a bunch of work that is completely unnecessary, right? Code for stuff you never needed to do, stuff you didn't even do, copy and paste a note from a template that makes it look like you did it, and then hope nobody notices. Well, 3 people noticed all of a sudden at the University of Washington, and these 3 docs are in serious trouble. And their defense is something like, I didn't know that would code like that. I don't do the coding. I just checked a box on the physical. I didn't realize that if I checked 6 boxes, that would be a claiming that I reviewed 4 organ systems, right? But the patient's saying the person never got up. One of them's our oncologist, and the patient says he never got up from his desk. He never did a physical exam. Went over my labs and sent me down the hall for an infusion. And the guy's billing a level 5 visit that the patient's smart enough to say includes these elements. We got problems. You're not allowed to just print money because you want more money. Right? And by the way, if you took your car to the Toyota or depending on your income level, the Mercedes dealer today, and you got that car, you brought it in for 36K service, and you figured that was going to be expensive because you bought a Mercedes, and then you get a bill back for things like, we changed the air in your tires, we warmed up your windshield washer fluid, and we sprayed bug repellent on the outside of your windshield, which will last about 13 minutes on a sunny day. But for those 13 minutes, bugs will be afraid to splat themselves on your windshield. And for that, we charge you an additional $211.55. How many of you would be bloody outraged? But yet, using the EHR encoding, we're doing stuff like that all the time. I was recently in a visit, a worried well person. I'm coaching a doc, worried well person, one of our docs, comes in, Amazon employee, you'd have to know Seattle. He's looking for a primary care provider. We have a UW clinic across from Amazon, and he has tweaked his knee while playing co-ed soccer about a week before, but it hasn't gotten better, so he comes to see one of our primary care providers. Here's how the visit goes. She spends the first 7 minutes with her back to him, filling out the Epic patient history. That's fine. No value to this patient, right? Then she turns to him and does essentially, how long do you think the exam of his knee was? 30 seconds, 35 seconds. I sit there with a stopwatch because I'm trying to help with this. Refers him, he tells him he could go to orthopedics or he could go to physical therapy. The choice is his. He looks at me. He looks at her. He said, this is advice, right? She says, and oh, by the way, while you're here, let me take a quick listen to your heart and your lungs. Ooh, how many of you say that on a regular basis? Worried well, 25-year-old computer programmer, tweaks his knee, and she's going to take a quick listen to his heart and lungs. Why is she taking a quick listen to his heart and lungs? Okay, you understand what I'm getting at then. Is that corrosive to your spirit? Is that undermining to your profession? And by the way, when we're seeing patients together, I walk to the elevator with this son of a gun, because I'm simply saying, the doctors at UW get observed from time to time. It was Dr. S's turn. Just wondering, do you have any impressions of the visit? He turns to me and says, what was all that about? So I said, what's the that you're wondering? He says, why is she listening to my heart and lungs? And he's a smart guy. He says, is that so she could bill me more? And then the elevator comes, he looks at me, winks, and gets on the elevator. He's never coming back. But I'll be curious, he's going to be watching. And Amazon employees have good insurance, but that son of a gun is going to be watching, because I'll bet she upcoded that thing. How many of you feeling a little sleazy at this point? I mean, this is one of the most noble professions on earth. And by the way, when you have to chart this crap at night, when you're there till 9 o'clock at night filling out this crazy EHR, is part of what's irritating you knowing that most of the stuff didn't need to get done or charted in the first place? Most docs I talked to said, I'm happy to chart the work that needed to be done in the patient's visit. What infuriates me is all the other nonsense I'm doing. And I say to them, if charting it's bugging you, did you need to do it in the first place? But I will leave that to you. In any event, we increase our suffering in a couple more ways. Negative contagion, right? In other words, you're in a good mood until you meet one of your colleagues, and he updates you on why you should be in a crappy mood. You're alienated from the patients. They become these people. You ever been among your colleagues and they say, these people? I had another one just come in yesterday. You wouldn't believe it. Fat as a house. Smokes cigarettes. She doesn't do anything. Personal hygiene's terrible. These people. It's like, as soon as you hear these people, think alienation. These people are somebody's mother, wife, daughter, sister. That could be my wife is one of these people. Right? Losing connection to the present moment, failing to let go and relax, forgetting to be grateful. I mean, does anybody in this room have something to be grateful for? If I showed you a picture of your graduation from medical school, would you be grinning from ear to ear? Would that actually be the culmination of essentially the first 24 years of your hopes and dreams? I mean, that's how excited you were to get entry into this profession. And you have every right to have been that excited. It's still a gorgeous profession. But change is normal. In any event, we have a couple of other ways. We can dehumanize the out-group. I was at a talk recently where this guy, I shouldn't say this, but this guy ahead of me, world famous, goes on and on about Obamacare, Medicare, Medicaid, these federal bureaucrats. He's going on and on about how these people are ruining his life because they make him justify why he's prescribing, I'm not going to say which medicine because I saw it out there, versus warfarin. I'm a citizen. I'm saying to myself, I hope to God, if warfarin would do, you'd prescribe it, because that money's coming out of somebody's tax pocket, right? But he's pissing and moaning like, that this is a crime that these federal bureaucrats are doing this to you. Well, I happen to have two patients who are federal bureaucrats. They're the hardest working people I know. They care deeply about the health care, not just of the patients this guy saw today, but of an entire nation full of people they're worried about. And I don't like hearing them slammed by somebody who's essentially just alienated and acting like all the physicians in the room should start to nod. Like, enter this hypnotic trance, everybody in Washington's an idiot. Well, I don't believe that's true. I believe there's a lot of people in Washington who care deeply about the health of 300 million people. By the way, this crazy deal with autologous bone marrow transplants that you may know about in California, the way the state of California had to respond to that crazy business, which, by the way, the California Medical Association pilloried the state of California. Rather than stand up for science, what happened was they went after the state legislature, took the side of the plaintiff. State of California had to start paying for autologous bone marrow transplants for breast cancer people, which, as you just heard, was of no value. And you know what the state of California had to do to pay for that? Reduced prenatal benefits for poor women. We helped them get away with that because our reflex was to think that everybody's a legislator, must be some kind of vicious creep. Come on now, got to be smarter than that about this stuff. There's not a them, there's not an us, there's a bunch of people trying to take care of the health of Americans, and we have different roles in which we do it. Right? When I was the chief of a department, it was amazing. I went from being a provider to being the department chair. One of my colleagues said to me, like a week later, you are really different now. I go, genetically? Did I do my hair? What did I do? Well, you're one of them now. Being maximally sensitive to our own distress and minimally sensitive to others is really fascinating. I hear my colleagues talk about our medical leadership in a way that if the medical leadership ever talked about that they would be in tears. But I have colleagues who say, oh, the medical director's an ass. He doesn't know what he's doing. These people. It's like, come on now. If they ever said anything like that about you and you heard it, you would be weeping in the streets. But we tend to be maximally sensitive. I mean, part of this issue in endocrinology the other day was what do we do to patients who are 15 minutes late? Well, the zeitgeist in the group is, we can't see them. They need to be reappointed. I thought that might make sense. I could see where that would be sensible. Until I asked the question of the practice leader, what % of the visits in this practice start within 15 minutes? Well, it turns out if you start telling patients who are 15 minutes late to go away and next time leave early, you are talking to people who have waited more than a half hour for you many times in the last few years. Is that going to feel equitable to you? You still have to solve the problem of what does a practice do with people who come late? It's a real problem. But this idea of these people don't care about my time, maximally sensitive to our hurts, minimally sensitive to theirs, sets you up for this antagonism. It's just not necessary. It's not true. What we say constantly, and here's another, if you don't like the AA prayer, try this one. The people are not the problem. The people are those with whom you're trying to solve the problem. The patient is not the problem. You are not the problem. The problem is the problem. The doctors who do well never make the patient into the problem. You're a person with a bad back who's been using opiates in an effort to live with the pain. You are not the problem. I'm not the problem because I could prescribe opiates for you and have for years. So you're not the problem. You're not a drug-seeking sociopath. I'm not the problem. I'm not a cruel, uncaring provider. But we do have a problem. What is the only problem we have? Remember, the doctors who do well with this, they don't make the patients the problem. They're soft on the people. They're hard on the problem. So the only problem we have is the amount of opiates you're using at the dose you're using it with the other aspects in your life is not the safest and most effective way to help you with this pain. As a matter of fact, I think there's evidence it's doing more harm than good. I could not let myself prescribe a medicine in a situation where there was evidence it was doing more harm than good. Are you open to any alternatives? That's an entirely different way to try to dial back the opiate misuse in this country. But not by making the patients the problem, because they're going to make you the problem. No, we're soft on the people. We're focused on the problem. By the way, you're not the problem. You came a half hour late for your appointment. I'm not the problem because I've been late for things myself. Traffic is crazy. Kids projectile vomit in the car, right? No, but we do have a problem. What's the only problem we have? Dr. O'Connell is fully booked for the rest of the morning, right? And he does not have the availability to squeeze you in. That's the only problem we have. You're not a bad human being. He's not a self-absorbed doctor. Soft on the people, hard on the problem is what allows people to have less stress in professional practice. Too much complaining wears people out. Insufficient gratitude wears people out. It's a formula, right? These are threats to self-esteem. If you keep dumping adrenaline and cortisol, you're going to wear yourself out. We took one of the loveliest trips we ever took was to Botswana a few years ago. Botswana, and now 2 years ago. One of the things as a shrink that stood out to me is we see lions. I mean, those of you who've been on safari or hunt, you watch these animals, right? There's an entire herd of these herbivores. Lion comes to the edge of their forest. You hear a snap of a twig. Everyone looks up. They run like crazy. But you know what they're doing 5 minutes later? Browsing grass in another field. Because unlike us, most of those herbivores have a very short memory for this stuff. Right? They can't be constantly anxious. An herbivore that's a nervous wreck living in Botswana is going to get eaten because she's not going to eat enough grass, right? But humans, we remember the past and we anticipate the future. And that is diabolical. Because now you can be dumping adrenaline and cortisol because of something happened last week or last year. Or you could be dumping adrenaline and cortisol about something that might happen next week or next year. I mean, thank God if you're a wildebeest in Botswana, you probably think you're in the present a good deal of the time. So in other words, if the present has the shape of a predator or a loud noise, you had better wake up and run. But when you've satisfied yourself that the predator is not present, go back to grazing. It's a better way to live. In any event, thoughts affect moods. That's what's different about us. Maybe other primates as well, but certainly for humans, our thoughts affect our moods. So if you want to make a change in the place you're most able to make it, and everybody in this room should consider, stop trying to change the world, right? Change this, right? Now, how do you change that? Well, I don't have an office in Ogden, and you don't need to see a shrink usually, because you're smart people. When you start to understand how you're thinking, you see how you increase your suffering, because you can observe your internal. If I said to you right now, this may sound spooky, how many of you are talking to yourself in your head right now? How many of you could write down the conversation in your head right now? And on the drive home, and at almost any time, if you paused, everybody in this room, I believe, is capable of dictating, translating the dialogue in the head. You know you are talking to yourself in your head. I talk to myself out loud sometimes, and I wear earphones to pretend that I'm actually on the phone. The ones who do this well, if you're going to, we have a softening about the world, right? I'm not right or wrong. I take these things as a hypothesis. So people who have less stress, they tend to see these things as a hypothesis, right? Check it out. I don't know. They tend to be more curious. They tend to be less certain, more curious, because certainty is a setup for trouble. In a world that's constantly changing, and you have setup is a trouble. If thoughts are distorted, they tend to increase suffering. So here's I'm going to go through a quick list of suffering. I want you to, you don't have to write this down if you don't want, but please take a fearless inventory, as we say in AA, of any of these things that you think you do on a regular basis, because I hope you have this handout or that's been given to you electronically, and I hope tonight you fire this thing up and take a fearless inventory, because I really do want you to suffer less. The first is all or nothing thinking, a formula for excess suffering. You see things as in black and white categories. If a situation falls short of perfect, you see it as a total failure. In other words, don't ever ask a closed-ended question or answer one if you can help it. Did you have a nice day, honey? Don't ever answer that question. It's a sucker's question. Was your day nice or not nice? Are there only two choices about a day where you've seen 25 patients, driven to work, texted your daughter who lives in San Francisco, visited with some friends, had a meeting? Is there a yes or no answer to that question? Do you like being a doctor? Don't ever let somebody ask you that question, and if they do, refuse to answer it. It's a sucker's question. The world is not black or white. Many things happened today. Some of them were more satisfying than others. Some of them went the way I hoped for. Some of them were different than the way I preferred. That's the more. If you want an answer from how was your day, that's the short answer. All or nothing thinking is a huge problem, right? So watch out for it, because you'll be forced into one of these two choices, and it is just not sensible. I was at a conference in California some years ago. People didn't know who I was, so I had lunch. I was having lunch because I was the next speaker. And it was when California had just done a survey, and 64% of California doctors said, I would discourage my children from going into medicine. I'm not going to do a survey here. I'm sitting having lunch. By the way, this is Palm Springs, California. I'm going to get to play free golf at this conference. And even though I'm a crappy golfer, free golf is a price I like. I'm walking through a parking lot full of late model luxury cars. I'm in Palm Springs. Did I mention that already? I'm from Seattle, Palm Springs, California, and I'm listening to this thing, and I'm saying to myself, this is fascinating. Right? Yes, no question. Would you encourage your children to go into medicine? But I'm sitting there, no one knows who I am, and I said, I guess, and at the table, people are resonating with this. So I said, 64% of people, 6 out of 10 of you would discourage your child from going to medicine. My next question was simply, what would you encourage them to do? The room falls silent. The table falls silent. No one has a bloody idea. Right? Because they got schnookered into a yes-no question and did not understand life is more complicated. Do you want your daughter to be my daughter's 5th grade science teacher? It's a beautiful thing. She will work her butt off. She will make $40,000 a year. She will live in the same city you do. Right? Or would you like your, I mean, here we go. Force yourself to make life more nuanced, and all of a sudden you start to feel less stress, because you're smart people and you see the more complex fabric of your life, right? Was Obamacare a good or a bad thing? Don't ever answer that question. It was good for some people. It added a strain to other people. Is that life? Right? We're going to Europe in a couple of weeks. I love to go to Europe, right? Ask somebody in Germany how they felt about the end of World War II. A lot of people lost that war. Some people won that war. Don't ever ask. I mean, even winning and losing is not so obvious, right? In any event, How about overgeneralization? How many of you do this? Always and never. Don't ever use the word always or never again. It is almost never true. It usually increases suffering. What would you do instead? I don't know. Are patients always late? I hear this stuff all the time from smart people. Patients are always late. Nobody cares. Nobody follows a treatment plan. That's just not true. There's no evidence for that. You would be diagnosed with a histrionic personality disorder if you did that for more than 6 months. Don't let yourself use always or never. And when you hear people using always or never, force them to say, so every patient all day long, nobody, 20 people, they all came a half hour late. You'll force yourself and other people to start to get more real. None of this is about Pollyannish. Most people would have much less stress and be much less depressed if they simply saw life accurately. By the way, in my state, you're allowed to smoke stuff to help you have a sense of equanimity. I hate that drug. Caffeine is my drug. I don't like to take any drug that makes me dumber than I already am. So that's overgeneralization. A couple more. The mental filter. I would say to doctors, like, so when you get home, what do you tell your spouse? Well, I tell my spouse about the most frustrating thing that happened today. And then what does your spouse tell you? She tells me about the most frustrating thing that happened today. I said, could you stop doing that? Before you pull into that driveway, I want you to do 2 things. The first thing I want you to do is say, as a matter of fact, I have doctors right now who we're asking to wear white coats. I don't know if you guys are wearing white coats anymore, but most of our docs stopped doing it. I have 6 of them that they now have to wear a white coat so that they have something to take off at the end of the clinic day. And when they take it off, they have to take it off, they hang it on the door, and they say this thing, which was not my idea, it was one of our support group people. She said, I hang it on the door and I say, I have just spent 10 to 12 hours at an incredibly important and valuable activity, and that is enough for one day. And then that you say, as you walk to your car, you say to yourself, I'm about to go to another setting where I have very important and valuable roles, and they need my full and undivided attention. And if you have any thought about the clinic day on the drive home, put it out of your mind. Turn up the radio, pray to God, do this. When you pull into that driveway, or rehearse what you're going to say when the people who love you say, how was your day? Right? Because you want your day behind you. Because everybody in this room does have important and valuable roles, more than just being a physician. You cannot let this job leak into the rest of your day and your life. Your husbands, your wives, your daughters, your sons, right? You have too many important roles. Being a doctor should not have been a lifelong prison sentence. So now we have doctors hanging up their coats, and they have to say, I've just spent 10 to 12 hours at an important and valued activity, and that is enough, unless you're on call, in which case we have a different mantra for you. Discounting the positive. I have doctors who come to see me. One will be inevitably, if a doctor comes to see me who's frustrated, I will say, I want you to, next week's appointment, bring your clinic schedule. It won't be HIPAA. I'll wear a condom. No one will get infected by this. Bring your clinic schedule, and I give them 3 pens. Red, yellow, and green. I say, mark, circle with green any patients where you say to yourself, that was a reasonably satisfying visit. I think I was kind of helpful. Circle with orange or yellow any visit where you say, I'm not sure how valuable that was. And then circle with red the patients who you say, that was so unpleasant. These are the people that are driving me out of medicine. I've been doing this for years with doctors. The most of 100 patients on average that the doctor saw in a week, the highest number of patients marked in red I have ever seen is 9. These are people sent to me because they're ready to quit medicine. What would you take from a person who's come to see you, sent by their medical director, totally burnt out, hate medicine, think they should never have gone into it, and when they come back with their clinic schedule, there's only 9 visits circled in red. Then there's usually 10 or 11 yellows. 80% of the visits are usually in green. I don't have to say anything. I give the form back to the physician. I say, what do you make of this? And inevitably, they say, the frustrating visits are taking up too much room in my head. I said, good, that's the place to start. Now let's find out. Once you know that, at least you can be grateful for the 80 visits. But now let's go back and find out what's going wrong 9 times. And let's even get that down to 3. Because it's an easier job to do if you don't have. I've never seen it higher than 9 in 10 years of doing this exercise. That tells you something about discounting the positive. Right? And you know what I'm talking about. You are very smart people. This is not ignorance. This is the human mind tending to focus on distress. It's probably evolutionarily sensible. It's like if you eat a mushroom and you throw your guts up, you probably should be very concerned about eating mushrooms in the future. But if only 9 out of 100 patients are creating an unpleasant visit, that should not be a reason to quit family medicine. Okay. Humans are constantly comparing themselves to others. You do that as well. The problem is that for the high achievers, the comparison, they're usually comparing themselves to other very high achievers, and so they're always schnooped when they do this. Like the woman who said, I guess I'm only going to be a family practice doc. She wasn't comparing herself to her high school graduating class, right? Because she'd have been the star in that group. How about jumping to conclusions, mind reading, fortune telling? We do that as well. Negative emotions necessarily reflect the way things really are. It's not true. I have patients for years. I was an expert in fear of flying for some crazy reason. And so these patients would get referred to me, and inevitably you'd say to a patient, so tell me what goes through your mind as you think about flying. And they say, it makes me deathly afraid. I'd say, in order to be deathly afraid, what must the person be believing? That air travel is what? Dangerous. That it's a hypothesis. So I'd say, so what's your evidence that air travel is dangerous? They usually had none, right? So then I'd say, this is interesting. You're not a neurotic mess, but you're learning something about human emotion, right? You hear the wheels clank. You hear about one plane crashing out of every 3 million airport takeoffs and landings. That got stuck in your head, and now you're distorting the risk of flying. As long as you're sitting there, what you need to do is get on that plane and look at the flight attendant. Does she look like this is her last day on Earth? Does she look like she's been giving Diet Coke to people for close to 31 years? Does anybody who works for this airline look like they're in a risky business? And the answer is, hell no. Why don't they? Because they know something you also know, but you have to now make very present to yourself. I have patients who had to read over and over again the mantra, air travel is safe, air travel is safe. Because to counter the emotional reasoning, in any event, enough of that stuff. Should statements will do this. Doctors are notorious type A people, but we all do this. Everybody says the patient should come on time. I don't know if they should come on time or shouldn't come on time. What's true, though, is you'd prefer they did. So let's use prefer. It's softer, and it doesn't act like there's an 11th commandment, a 12th commandment. You know, I'm not sure. The last I looked, there were 10 commandments. None of them involve patients should come on time. So let's get back to, I would prefer they came on time. I would prefer you didn't have 12 agenda items in a 15-minute visit. But you know what? I would prefer to know that you have 12 agenda items, because then I can look at you and say, that may be more than we can do justice to in the time set aside. Let's together choose those items that are most important we get a jump on today, and then let's lay out a plan for how the rest of your issues are dealt with over the next few visits. I can deal with patients who have 12 agenda items in a 15-minute visit. It isn't like they shouldn't or they should. By the way, those of you who think the patient should have a chief complaint, get over it. The average number of things an adult medicine patient wants to talk about in a primary care visit is 3.4 for internal medicine, 2.8 for family medicine. If you're looking for the chief complaint, you are looking in the wrong place. Get over it. Start making a list of things that the patient wants to talk with you in today's visit. And the chief complaint is the first. So I understand you made this appointment because your stomach was bothering you. In addition to that, are there other things we need to take a look at while you're here? Get the list at the beginning. Stop acting like people shouldn't have a list. They have a list. And then you can see the rest of this. To untwist your thinking, you got to catch these distortions, and you got to soften the way you're thinking. So when I tease you about don't ever answer a yes/no question, you want to catch those. If I tease you about saying, watch every time you hear or say always or never, that is a stress reduction strategy. When I tease you about take everything anyone ever says to you as a hypothesis, it is possible that Obama has ruined America. What's your evidence for that? What's your evidence for the fact that good things have happened during his presidency? I don't care what your politics are, but it's unlikely that the man has ruined America. And by the way, I'm getting my head around the fact that it's unlikely Trump could ruin America. Although that's a steeper climb for me. Steeper climb. You got to think in shades of gray, right? Because the world is in shades of gray. You've got to ask for genuine feedback. If you leave this thing, and people will answer. If you go home and ask your spouse, honey, do I sound and look irritated? Do I sound and look negative? Ask your MA. Do I get grumpy? And listen to what you're getting back. That will give you feedback about where you are. Because this will all feel normal to you. And by the way, with the high levels of burnout reported by American physicians, you're probably getting a distorted vision of yourself in the mirror because your colleagues probably agreeing with you. Yeah, you wouldn't believe the patient I had yesterday. She was dumber than yours. These people, Enough. Let me get to the end because you need me to do that. And then if people are willing to ask a question, I'd love to hear it. But I'm going to leave this slide up while you ask these questions, if you have any, or you're allowed to protest as well. Because I encourage you to get home tonight and say to yourself, what are the thoughts I have about being a doctor? Just take them as a hypothesis, right? And then say to yourself, is there anything about that that's distorted? And if it is distorted, go to the right side of the column and say, what is a more accurate way of dealing with that frustration than I do right now? But let me stop there and say, concerns, questions, objections? Run, honey, run. You should have known you had a question. You should have been standing there.
No, I think one of the most frustrating things for me as a physician is when a patient has an expectation to get something and I maybe don't think that's the best treatment for them. And so I want to help the patient, but it seems like for me coming up with an alternative or something else is not going to satisfy them. They want this one thing.
Why do they want it?
Because they think that's going to help them.
Then let's talk about that. So when do you want to know that Mr. O'Connell is saying to himself, I'm not leaving here without an MRI scan? The beginning of this visit, somewhere in the middle, when you get up to leave and he says, oh, by the way,
Yeah.
I'd like a scan. See, what we do is we take every request or demand of the patient and we make it into a question. So, Mr. O'Connell, it sounds like the most important question for today is whether an MRI scan would add useful information to help us understand why your back is bothering you, or whether there's a less expensive or easier or more straightforward way. Let's answer that question together. But we need to know what the patient expected at the beginning of the visit, so that's how we budget the time to know. If we reach an impasse, we'll do this. We'll say, obviously, Mr. O'Connell, I'm not the only doctor in Seattle. Mm-hmm. I could understand where, with your experience and what you've read on the web and talked to in the past, you may believe that 120 milligram morphine equivalent is a safe dose for you. And if you do, I would encourage you to get a second opinion.
Okay, thanks.
I don't have to get furious in order to be curious. Other questions or comments, or most of you hoping lunch is going to be served 5 minutes early, or...
So how do you solve the electronic medical record and you have to face a computer to type, and if you don't do that, you've added 5 minutes to your encounter to try to do it after?
Quick thoughts about the computer. Most patients think a modern doctor should be using a computer in their medical visit. That's the good news. A third of them don't like the way we use it. That's the bad news. So we ask them, what is the doctor doing in those visits where you're glad he has the computer, she does, and what are they doing that infuriates you? And here's what we learned in a nutshell. If you took this research and divided it in half, the patients who are glad you have a computer, don't complain about it, they see how you used it to enhance their care today. The ones who don't like the way the doctor used it never saw how it helped their visit, so they saw it as a distraction. Why is he typing so much? Why is he clicking so much? So we say to patients, Mr. O'Connell, give me a second to open up your electronic health record so we can take advantage. And then we keep pointing out to this guy why it's a good idea I have this. I can see our notes from previous visits. I can look up your labs. Let me enter those prescriptions while you're here so they're waiting for you. Then when the patient says, I saw the gastroenterologist, I didn't understand a damn thing that guy said. If I'm at Intermountain or UW, or I say, that's okay. I can open up a copy of her note right now, his note right now, and let's go through it together and remind ourselves. Then I turn the screen so the patient can see it. Then I print out a copy of the report, and they love me. The thing about typing, we need to show them why is it in their best interest they let us type. So what is your first name up? My first name? Yeah. So Robert, would it be okay with you if I get some of this down while it's fresh in my mind? Like, he's a smart guy. He says, yeah, if there's going to be a recording, let's have it while it's fresh in O'Connell's mind. If I'm going to talk for more than a minute or two, more than 5 seconds, I talk out loud because patients have a tendency they can't stand silence. So now while I'm typing, I talk. So let me see if I understand this correctly. Depression started some years ago. You did well with counseling. then some years ago you tried an antidepressant, and then it came roaring back, and you're wondering if there are new medications that might be helpful. Do I have that correct? If I talk while I'm typing, the patients don't mind. They even feel like they're helping me create a more accurate record. If they want to change anything, let's change it now. I don't want to amend this note later. And by the way, at UW right now, we're on open notes. Patient can log on tonight and read my progress note. Virginia Mason, log on tonight, read my progress note. Beth Israel, where I'm going in 2 weeks, they log on tonight and read. And by the way, they read your progress note, not to try to get you, but because they are genuinely curious. They want to partner with us. They want to understand what we're doing and saying. And we print them a copy of their after-visit summary, and they love us. Crazy. Okay. And somebody's going to come with a long hook. Or say lunch is ready and the bell will ring. But until then.
Where in our lengthy training time do you think these lectures belong, or where are they in our medical training?
So I was doing a program at Virginia Mason in Seattle. Some of you may know Virginia Mason because it's the queen of lean. So they go around the country talking about lean. So I had 15 people in a day-long program. 5 of those were coming back for the 3rd time. I've been doing this program for probably 8 years. And these are experienced docs. One's a medical director, one's a section, 2 are section heads. And we go around and we introduce ourselves, and these guys say, I come every few years because I need a reminder. And this is not just well-being, this is doctor-patient communication stuff. I think it needs to be everywhere in the training, and then we need to remind ourselves. It's like asking me, why do I take golf lessons periodically? I've been playing the game for 35 years. I take lessons because the ball doesn't always go where I want. And these guys seem to know how to help me to get it to go where it wants, rather than me hitting bucket after bucket of balls and cursing. Better for everybody. I think that's a sign that we're done. I am going to give a couple more talks over the course of the next day and a half, so that would be a good time to schedule have your hair done or your nails or something, if you thought this was goofy. But thank you for letting me talk to you.